Hello. I will be talking about the ERAS protocols in ventral hernia repair. After all these great videos, let me launch you to the ground floor and get some details about the rehabilitation in ventral hernia repair. I have no conflict of interest. So the ERAS protocols is a set of multifactorial evidence-based protocols that aim to improve postoperative recovery, reduce hospital length of stay, and improve overall patient outcomes after major surgery, just like abdominal wall reconstruction surgeries. The background of ERAS is 1990. There were some studies that showed multimodal strategies that reduced the recovery time. And 2001, the ERAS Society was established. And 2005, there was the first consensus guidelines published for ERAS. And presently, we have a lot of ERAS protocols, especially in colorectal surgery, as you may know. The key points of ERAS protocols are multifactorial analgesia, targeted intravenous hydration, and standardized use of drains and catheters, early feeding, early mobilization, and systemic bowel mobilization. Now, the mechanisms of improvement in ERAS protocols are the early feeding that promotes faster return of bowel function, the early mobilization that prevents complications and speeds recovery, the fluid restriction that prevents overload and related complications, and multifactorial analgesia that reduces pain without the opioid side effects. Now, ventral hernia repair is one of the most commonly performed surgical procedures worldwide. And patient optimization before surgery has received increasingly focus in recent years. And this lecture evaluates current literature on patient rehabilitation prior to ventral hernia repair. So we're going to see what there is for ventral hernia repair protocols. Searching at the ERAS Society official site, there are a lot of guidelines for too many different subjects like bariatrics, neonatal, anesthesiology, colorectal, but no hernia ERAS protocols. So my search strategy for this lecture was I searched my search performed using PubMed, Cochrane Library, Web of Science, but AI power tools like Perplexity, Open Evidence, Academic, and Scholar Semantic. The types of studies that I was reviewed were reviews, systematic reviews, meta-analysis, and prospective studies, and the time period I chose were from 2010 to 2025. There were a lot of publications, a lot of studies, but let's stay in mainly 2 or 3 of them. The first one is the consensus in ERAS protocol for ventral hernia repair. It's the ACHQC, the Abdominal Core Health Quality Collaboration, that has studies, examined elements in ERAS protocols from institutions across US. So in this study, we have 4 patient care cycle stages. The pre-admission optimization, the perioperative care, the intraoperative care, and the postoperative management. Okay. So the pre-admission, let's see some elements. The nutritional evaluation, benefits shown in various patient population, but evidence specific to hernia population is absent. So no recommendation for nutrition evaluation. The European Hernia Society found no studies specifically addressing preoperative nutrition for ventral hernia repair. The weight management, strong recommendation, but weak evidence. Preoperative weight loss for elective ventral hernia repair is strongly recommended, but we have weak evidence. The functional status assessment the pre-admission functional status assessment. So the common criteria is the ability to climb 2 flights of stairs or subjective determination of diminished functional status. So the recommendation is that patients with poor baseline functional status should undergo physical therapy pre-operatively. Smoking cessation, it was really interesting that 2 institutions in this study were using urine testing to confirm smoke cessation. We don't have this in Greece, as long as I know. The smoking increases the risk of wound, respiratory and infectious complication. They suggest to stop smoking more than 4 weeks preoperatively. So the recommendation is to smoking cessation strongly advised for overall health benefits. The obstructive sleep apnea syndrome is very important. They use the stop bank test. This is a specific test. It is called stop bank. It's an acronym. It's a very serious matter that increases more than 30% the risk of complications with people that have OSA undiagnosed, and 100% recommendation strength fully recommends screening and treatment of OSA before surgery. Diabetes management, European Hernia Society guidelines recommend good diabetic control prior to surgery, and this is the recommendation. We should develop appropriate post-operative glucose management plans. Now, concerning the pain management, the most common regimen includes acetaminophen, so paracetamol, celecoxib, gabapentin, Neurodin in Europe. TAP blocks are universally mentioned as an option for regional anesthesia, so you will always consider TAP blocks in your surgeries. Now, the pain management should have a multimodal approach. Multimodal analgesia should be used to reduce postoperative opioid consumption, and TAP blocks and regional blocks may be useful adjuncts. The nausea and vomiting syndromes, the postoperative nausea and vomiting prevention is another matter. So we should use multimodal approach. Combination therapy consistently more effective than single agents, and the ERAS Society and Society of Ambulatory Anesthesia both recommend multimodal approach. So the extubation planning, another very serious matter. There were a lot of studies that had protocols outline the extubation planning. 3 use plateau pressures change of more than 6, 2 more than 9 millimeters of mercury. Additional considerations include COPD, dyspnea, long operation, ASA more than 4, low albumin, and recurrent incarcerated hernia. So the extubation planning, in case we have we have to assess airway pressure via plateau pressure changes from pre to post fascial closure. Change of more than 6 millimeters of mercury indicates higher respiratory complication risk, and patients with significant pressure changes should be considered for post-operative intubation. So you should always measure the plateau pressure in case of difficult and big ventral hernia repairs. The postoperative pain management, continuous analgesia, epidurals, IV lidocaine infusion or PCAs until the 2nd or 3rd postoperative day, scheduled oral analgesia, and rescue analgesia with oxycodone. These are the recommendations. Postoperative mobility, the recommendation is strongly recommended when safe after elective ventral hernia repair. always mobilize the patients very early in their postoperative course, set clear, achievable mobility targets that increase each postoperative day. And VTE prophylaxis, of course, strong evidence, significant evidence supports clinical VTE prophylaxis following abdominal surgery, either enoxaparin or heparin subcutaneously for VTE prevention. Postoperative administration within 24 hours appears safe and effective. Now, I would like to stress two or more things from another great study from European Hernia Society. The intragastric balloon therapy, in order to reduce the weight, the limitations include lack of randomized study and associated costs. So the level of evidence for intragastric balloon before any operation for complex ventral hernia repairs is evidence too. But a staged repair of ventral hernia, so to do a gastrectomy, a sleeve gastrectomy before the operation in order to lose weight, this staged approach appears to decrease postoperative morbidity and recurrence rates, especially in cases of large defects, complex hernias, and asymptomatic patients. And regarding the type of bariatric procedure of choice, laparoscopic sleeve gastrectomy seems the best, because there's no manipulation of the intestine, and this procedure is with low postoperative risk. So risk factors for complication is obesity, smoking, diabetes, and surgical site infections. The conclusion is that smoking cessation and preoperative weight loss counseling showed potential to reduce complication, but we need future studies addressing this gap in literature. So overall, with my search, with all these studies and meta-analysis and reviews, we have a 0.9 days reduction after surgery, 0% increase in complication if we follow ERAS protocols, and elevation of quality of life. There is evidence of faster return to daily life, less fatigue, and faster return to bowel functions. So our special findings include patients with smaller hernias, shorter surgery times, and better preoperative quality of life benefit more from ERAS protocols. In robotic abdominal hernia surgery, ERAS protocols resulted in high same-day discharge rates and low pain levels. So we should use minimally invasive surgery if we can. In more complex procedures with large hernia or component separation, the reduction in hospital length of stay may be less significant, but the safety and recovery benefits remain. So the key findings on recovery time is length of stay. There was a diminished length of stay of 0.9 days. There was a statistical significant raise in quality of life, and there was no statistical difference in readmission rate and infection rate if we follow ERAS protocols. But there were some heterogeneity in results. There was statistical significant. There was a statistical significant. Some studies showed no significant reduction in hospital stay. There was larger and more complex hernia showed less benefit. Longer operations influenced recovery time, and there were some patient factors that prevented quality of life after ERAS protocols, like these studies from great centers, like the first one is among the authors is Todd Heniford, or the second study is from Rosen and Prahu and Karpata, that say that in this cohort ERAS failed to reduce length of hospital stay, and they confirmed that a subset of patients with greater benefits from ERAS should be smaller hernia defects, shorter operative time, and higher baseline quality of life scores. So only patients with smaller hernias, shorter surgery time, and better preoperative quality of life seem to benefit substantially from ERAS protocol in terms of reduced hospitalization. And these are the patient factors that are limiting ERAS effectiveness. So high SAA score, complex cases, protocol compliance, poor nutrition, advanced age, and complications that will affect the ERAS protocols not to deliver the benefits we should expect. So pre-admission optimization, to conclude, nutritional status, weight management, smoking cessation, comorbidity management, and patient education. Pre-operative care, multifactorial analgesia, avoiding prolonged fasting, pre-operative hydration, bowel preparation. Intraoperative care, minimize surgery time, minimally invasive techniques where it is possible, limit drains and catheters, and proper mesh placement, accurate placement and fixation of the mesh according to abdominal wall repair principles. Post-operative management, early mobilization, early feeding, continuous analgesia, complication monitoring, and catheter removal. The use of robotic surgery in combination with ERAS has shown high same-day discharge rates and reduced pain levels. And don't forget that every complication costs. So infections doubles the risk of hernia recurrence. Complications increase hospital-associated expenses, and complication reduced patient-reported quality of life. So investing in prehabilitation in ERAS protocols may reduce overall healthcare costs by preventing expensive complications and improving patient outcomes. Thank you so much.